Management of post-operative nausea and vomiting. Post-operative nausea and vomiting, which will be referred to as PONV, is defined as nausea and/or vomiting occurring within 24 hours after surgery and is a common and distressing complication for many surgical patients. This incident generally occurs with vomiting at about 30%, with the incidence of nausea at 50%, even rating as high as 80% for high-risk patients. Patients suffering from PONV appear pale, clammy, tachycardic, restless, actively vomiting or dry retching, and can have a decreased blood pressure. The complications of PONV are psychological, economical, and physical. Research has identified that patients who suffer from PONV experience anxiety, distress, shame, and embarrassment. Patients find vomiting a more disagreeable and feared outcome of surgery above that of pain, often causing a fear of further surgery. PONV is also associated with increased healthcare costs, from unresolved PONV prolonging a patient's stay in the post-anesthesia care unit and unanticipated hospital admission. The most important complications to consider are physical, as they can be life-threatening. These include airway obstruction, aspiration pneumonia, electrolyte imbalance and dehydration, pain, and delayed recovery. Once aspiration has occurred, there is a 50% chance the patient will suffer a major morbidity along with a 4% mortality rate. Various risk assessment tools have been devised to assist and guide health professionals in identification of patients who are expected to suffer from PONV. It is important to know that despite using a risk assessment tool, none can predict the probability of an individual to experience PONV, but are only to estimate the risk of it amongst patient groups, allowing health professionals to identify who would be most likely to benefit from prophylactic antiemetic therapy. A simplified risk score has been devised, identifying 4 main risk factors to objectively measure the prediction of PONV baseline risk. These risk factors are female gender, non-smoking status, history of motion sickness or PONV, and use of post-operative opioids. Each of these risk factors increases the likelihood of PONV by 18 to 22%. It is also important to consider the type of anesthetic that was used, as this is the most likely cause of PONV. Volatile anesthetics, nitrous oxide, and post-operative opioids add to the risk of PONV. The use of PONV prophylaxis for everyone is not cost-effective and creates an unnecessary risk for drug-related adverse effects. A number of strategies can be implemented to significantly decrease the risk of PONV. These include the avoidance of general anesthesia by supplementing with the use of regional anesthesia, preferential use of propofol infusions, avoidance of nitrous oxide, avoidance of volatile anesthetics, minimization of perioperative opioids, and adequate hydration. The use of regional anesthetic is beneficial to use when possible, as general anesthetic is associated with an 11 times increased risk of PONV. A study concluded that the combination of propofol and oxygen had effects reducing the PONV risk by 25%, along with the findings of avoiding nitrous oxide to further reduce the risk. The baseline risk for PONV can also be reduced by the minimization of the use of post-operative opioids, instead opting for an alternate pharmacological approach for pain management, such as non-steroidal anti-inflammatory drugs. However, the increased risk of post-operative bleeding must be considered. The benefit of using regional anesthesia in combination with general anesthesia also reduces the requirement for post-operative opioids, therefore reducing the risk of post-operative emesis. The simplest strategy to reduce PONV is adequate hydration by perioperative intravenous fluid administration. When prophylactic treatment is considered after identifying a patient of moderate to high risk of PONV, pharmacological antiemetics are administered. There are various drug classes of antiemetics. Some include serotonin receptor antagonists, corticosteroids, dopamine antagonists, butyrophenones, and antihistamines, and more. Combination antiemetic therapy for POMV prophylaxis is more effective and preferable to using a single drug alone. Adults that are at moderate risk for POMV should receive a combination of antiemetics from different classes. For example, serotonin receptor antagonists are a more effective antiemetic, which can be used in combination with a butyrophenone, which has a greater anti-nausea effect. When persistent nausea and vomiting occurs, it is important to consider other contributing factors, such as presence of blood in the pharynx, abdominal obstruction, or patient-controlled morphine analgesia. These contributing factors should be excluded before pharmacological treatment is considered. When POMV occurs, treatment should be an antiemetic administered from a pharmacological class that is different to the prophylactic drug that was initially given, or, if no prophylaxis was administered, the recommendation is a low-dose serotonin receptor antagonist, such as ondansetron. Acupuncture is a method of POMV treatment that is non-pharmacological. Studies suggest that the management of patients with POMV is disorganized and inconsistent. Irrespective of the extensive amounts of research on POMV prevention and management, the existing guidelines are poorly implemented. Poor education is not the cause for the reluctance to administer appropriate POMV prophylaxis, as the problem persists even after intense educational services and activities. The suggestion to improve the compliance amongst the clinical environment would be perhaps to implement a more practical risk assessment that involves a more preventative strategy.